Hello everyone, how are you all? Welcome everyone to First Aid AMC MCQ free 2-week session, right? So we're on the verge of finishing our free 2-week trial session tonight. And I guess that you guys have been enjoying the session so far, right? So tonight we're going to discuss some of the sample questions, and again we will go through the tips and tricks of solving some questions, right? Now, again, as I always say, that questions are important to get your idea about the theory, and you get to know the theory most out of this sample question solvation. Never ever memorize any questions and its answers, because it doesn't help in your exam. Okay, so whenever you solve some questions, like you can do it from a QBank, you can do it from our software. So wherever you are solving the questions, what you actually do, or what you try to find out from that question is that, do you know that particular theory properly or not? Is your basic or theory knowledge about that particular question is up to date or not? So that's what you want to find out. If you can't find out the answer, if you are confused, that means that you need improvement in that particular topic. So at that time, what you do, you just memorize the answer and then you move forward? No. What you should do is to go through a lot from lots of websites and guidelines about that particular topic. And that's how you improve yourself, right? So in the exam, if something related to that particular topic eventually comes in your exam, then you will know, right? So and you will be confident with your exam. Now that you know that there is no more flagging in your exam, that means you have to be right. You can't just answer a question, whatever you think about, and then just move on and then come back at the end of the exam. No longer this is happening. And this is, I guess, like this is harder, obviously harder than before. Now you need to be absolutely right when you are clicking on a particular answer in your exam. Okay, so and that's it. You cannot change it back. So this is really tougher than how it was used to be done before. Previously, when like even when I appeared the exam, what like normally, like let's say one question is very hard or very big, what we used to do is to just answer that question even without reading properly, and then flagging that question and come back after I finished 150 questions, because then I can give more time in that particular question. And that was good in my view, and I guess like in terms of all of your view, it was good and easier. But now you need to read that bigger questions or sometimes very tough questions. You need to answer it, because once you answer it, you can't change it, right? So that's an important thing. Now you need to really work on your theory knowledge. You cannot memorize questions or its answers. It's never going to help you in the exam. Okay, so make your theory very good and apply that knowledge in questions, and you will understand that it's not hard. Once you understand the tricks of a question, then it's really easy to find out that something in that question, is it a clue for your diagnosis or clue to your answer, or is it some kind of trap? Sometimes the traps are very easy to find out, because like if you see something is very evident, like they're just giving you everything in that particular question, or like they want you to answer particular thing, that's most of the time it's not the answer, because they just want you to think in that way. Okay, so you need to always think like as a logic, and also trying to find out that, is it a trap? Okay, am I going to fall into a trap or not? So finding the traps in an exam question is really important. Once you can identify those traps, it becomes very easy to get your answer correctly. Okay, so this is how we are trying to build up throughout these 3-week sessions, and also throughout the course, we will try to build this up so that you know which one is the clue to the diagnosis or clue to your questions, or which one is the actual trap given by the particular examiner to you. Okay, so that's important. So let's start our question solvation class today. Guys, as you know that this is our last session for 3 weeks. So I would advise you, if you guys have any questions regarding the course, feel free to ask me at the end of the class. Okay, I'll be here at least 10-15 minutes after the session just to answer your questions. So if you have any questions, anything that you want to know about the course, you should ask it today. Okay, and again, like I'll just go through like about the course at the end of the class. Okay, now we start our class tonight and let's move on. It's a beautiful PowerPoint, right? I'm really loving this one. All right, so this is your first question. A 30 weeks pregnant lady presents to the emergency department with acute shortness of breath and chest pain started this morning. So you have got a 30 weeks pregnant lady presenting to the emergency department with acute shortness of breath and chest pain. Okay, so obviously this is a acute presentation, no fever, cough, or hemoptysis. On examination, blood pressure is stable, pulse rate is little high, history of travel recently. This is a very important clue, right? Someone who is 30 weeks pregnant, having a chest pain and shortness of breath, having tachycardia, and having a recent history of travel, you should immediately think about what? What is your most likely diagnosis in this case? Pulmonary embolism, definitively, right? So obviously it should be a pulmonary embolism case. You did a chest x-ray and it came normal. Can you exclude pulmonary embolism by doing a chest x-ray? No. Why we do chest x-ray in this case? Sometimes, like if you are not sure about your diagnosis or this patient doesn't have high criteria to diagnose pulmonary embolism, then just to exclude some of the other causes, like let's say pneumonia, pulmonary pneumonia, pneumothorax, to exclude those things, you do a chest x-ray. But in this case, no need of doing it. Like even if you don't do a chest x-ray, when you already understand this patient having a pulmonary embolism, that's the way to do it. You don't need to do anything if you think that this is a case of pulmonary embolism. And how you know it? You need to know the Wales criteria to understand that who are high-risk patients and who is like who you should think having a pulmonary embolism in the first place. Like pregnancy itself is a risk factor of having thromboembolism. Okay. On the top of that, this patient having a history of recent travel. So two risk factors. On the top of that, patient's symptoms goes with pulmonary embolism with a tachycardia, which is the most common signs in pulmonary embolism. So you have got lots of findings which goes towards pulmonary embolism. In this case, you need to think about which can diagnose the condition. So you don't need to do chest x-ray, you don't need to do ECG, you don't need to do anything. Once you get like a high risk criteria and the most likely diagnosis is PE, you don't do anything. Your next best everything becomes diagnostic imaging. Now, diagnostic imaging, depending on the patient factor, depending on the gender of the patient, it is different. The most commonly we do CTPA, but because this is a pregnant patient and CT scan involves radiation, we try not to do CTPA in a pregnant patient. Okay, so in pregnancy, the VQ scan is a diagnostic test for pulmonary embolism. Now you can ask me that, will this patient having chest pain? Why I'm not doing a ECG in the next step? Because it's not important at the moment. 30 weeks having ischemic heart disease, not very common, right? And also the all other feature doesn't go with ischemic heart disease or myocardial infarction. If this was a 50 or 60 weeks patient, not a pregnant one, we could do a ECG because they are high risk. Okay, so depending on the context of the question, we need to think in that way also. Now, apart from a pregnant patient, we would always do CTPA when we think it as a pulmonary embolism. Now, tonight, I'm going to discuss a little bit about pulmonary embolism so that you guys understand it perfectly. So this is your RACGP guideline, very good guideline. So always try to find out these medicine-related cases from RACGP. So what is pulmonary embolism? That means the pulmonary artery is blocked with the embolism. Okay, so somewhere from the body, a clot has been dislodged, and now it's blocking your major pulmonary artery or its branches. When someone develops pulmonary embolism, that means the lungs are not getting blood supply. If your lungs are not getting blood supply, you develop chest pain, you develop acute shortness of breath. And the chest pain in here, it's kind of pleuritic in nature. That means it gets worse with cough, with taking a deep breath, okay? And sometimes patient can also have hemoptysis. With that, if you look at the vitals of this patient, the most important finding you will get is tachycardia, tachypnea, and hypoxia. But among these three, what is the most common sign? Tachycardia. It comes in exams, so very important. Okay, now risk stratification is important. When we think about having a PE, we need to look at some of the risk factors. These are the risk factors of having a pulmonary embolism. So someone who had a recent surgery, which was especially joint surgery, let's say hip replacement, knee replacement, or having a recent femur fracture. Okay, so lower limb surgery is very high risk of having a pulmonary embolism. Someone who had a major operation, let's say abdominal operation or pelvic operation, they are also high risk. Any chronic medical illness like a cancer patient, they are high risk. Active malignancy, myeloproliferative disease, or even someone who is currently getting anti-cancer treatment, they are also high risk. Hormone-related pregnancy, postpartum, patient who is taking long-standing OCP or hormone replacement therapy, they are high risk. Patient with a family history of clotting problem like thrombophilia, they are super high risk. Obesity, especially if their BMI is more than 30, they are high risk. And very important is if there is any past history of deep vein thrombosis or pulmonary embolism. Prolonged immobilization, like someone, let's say that they are bedbound, like a nursing home patient, they are high risk. Recent travel history, like a long travel, especially more than 4 hours duration. So these are all high risk patients to develop pulmonary embolism. Once you get to know their risk, you follow this Wells criteria to see that if they are high risk or low risk of having a DVT or concurrently pulmonary embolism. So you look for clinical sign and symptom of DVT. If you think that all the features your patient is having goes with deep vein thrombosis, you can give a Wells score 3. Deep vein thrombosis and pulmonary embolism is different, right? So DVT means the patient having pain in the cough, pain and swelling and redness in the cough. So the clot is in the cough, okay, not in the lungs. When clot comes into the lung, it becomes pulmonary embolism. So if you get a sign and symptom of DVT, Wells criteria, you get 3 score. If your most likely diagnosis is PE, Wells criteria says it's 3 score. Heart rate more than 100, that means tachycardia 1.5. Recent immobilization or surgery 1.5. Previous history 1.5. Hemoptysis 1. And malignancy treatment or palliative patient 1. So obviously you understand these are the most high risk criteria, right? Now in our patient, what you have got? You have got immobilization, like recent travel history is immobilization, so 1.5. You have got heart rate more than 100, so 1.5, so already 3. And this patient's most likely diagnosis is also PE, so 3. So this patient actually having 6 point in Wells score. More than 4, definitely you need to do an imaging. So any Wells score, if it's more than 4, that needs imaging, nothing else. And what imaging we would do? We don't go for D-dimer in this case. we go immediately for a CTPA, or if needed, then VQA scan. All right. Now, let's say if someone's Wells is less than 4, then you can do a D-dimer in that case. But D-dimer, remember, most of the time it's not an answer in your exam because D-dimer is a non-specific investigation. It can be positive in many cases. Like a pregnant patient, if you do D-dimer, most of the time it will be elevated. Okay, so pregnancy itself can increase D-dimer. So it's very non-specific for this kind of patient. Okay, someone having a recent or ongoing infection or inflammation, D-dimer can be elevated. Cancer can increase D-dimer. So lots of other things can also increase D-dimer. So you don't rely on D-dimer to diagnose deep vein thrombosis. Okay. All right. So now come to your imaging. If imaging required, this should be performed as soon as possible and urgently. You don't need to worry about doing a chest X-ray, doing a ECG, doing all the blood tests, and then when patient is dead, you are thinking about doing a CTPA, because this patient can die in front of you within minutes, and that's an avoidable or preventable death. If you just give some anticoagulant, this patient will live. And now you're doing all the tests just to exclude your other differential diagnosis, whereas you could do a CT scan and you can start anticoagulant to that patient and patient would live. So this is one of the cases where we don't wait for doing all the initial or baseline investigation. We send the patient immediately for a CTPA if it's needed. Okay. Now, one of the problem that happens is the pregnancy. In pregnancy, we would rather go for a VQA scan. Also, if your VQA scan is not very commonly available in all hospitals, whereas CTPA is available in most of the hospitals. So availability is also an important part. Now, before doing a VQA scan, usually we want to find out that if the patient's X-ray is good. That means if the chest is good, because we can only rely on VQA scan if someone doesn't have any underlying chest condition. So that's why sometimes we want to do a chest X-ray to find out that if this patient having any baseline chest related problem or pathologies. If that is excluded, you can immediately go for a VQA scan. Okay. Now let's say someone having contrast nephropathy or someone having contrast allergy. Can you do CTPA? No. So then you may need to do a VQA scan. Someone having a severe CKD or kidney failure, which test you will do, CTPA or VQA scan? VQA scan, because you are giving contrast and you don't give contrast in a patient who is having a CKD, especially for like end-stage CKD or severe form of CKD patients. So these are the important things you should think about when you're looking into the question. You can do CTPA in a patient who is not pregnant, but rather in a reproductive age group. Like let's say a 30-year-old female coming to you, but with the PE feature, and the patient is not pregnant, then you would do a CTPA. You don't need to do a VQA scan because of the increased risk of radiation-induced breast cancer in a reproductive age group. We don't need to do that. So normally we can do CTPA in every patient, whatever it is, unless it's a pregnant patient. And like if it's a very young patient, like a 20-year-old having a PE female patient, you would rather do a VQA scan rather than doing a CTPA. All right. Now, another thing which is important in terms of pulmonary embolism, let's move on to your next question. So this question answer, we know it will be VQA scan. Now, similar question, but I want you guys to read the question and answer it. So what do you think that this question answer would be? So 30 weeks pregnant lady present to the ED with acute shortness of breath and chest pain, started this morning. No other features. On examination, blood pressure is okay, pulse is increased. There is right cough tenderness, swelling and, right cough redness, swelling and tenderness. What is this one means? And this patient having history of travel. So this patient having DVT causing pulmonary embolism. When you get DVT features in the question, that means patient having deep vein thrombosis symptoms and signs, then do we need to do a VQ scan or we can just do a Doppler ultrasound? Yes, very, very good, guys. So if you do a Doppler ultrasound of, can we do an arterial Doppler to diagnose DVT? No. So sometimes in the exam question, you might get like this arterial Doppler. So people, they just think that, well, Doppler is here, let's do a Doppler. But they're talking about arterial Doppler. What arterial Doppler will give you? When we do arterial Doppler, guys, yeah, so peripheral vascular disease. So if you're thinking about peripheral vascular disease, then you do an arterial Doppler. But you are thinking deep vein thrombosis. So the name is here, deep vein. So you need to do a duplex or Doppler ultrasound of the vein. Okay, so in this case, if it's a pregnant patient having a deep vein thrombosis, on the top of that, patient also having features of pulmonary embolism, you don't need to do a VQ scan, because if you can find out this patient's Doppler showing DVT, this patient obviously having a pulmonary embolism. So you don't need to worry about doing a VQ scan to diagnose it. If you do a Doppler, you find out this patient having deep vein thrombosis, you immediately treat the patient as a pulmonary embolism case. So a couple of things, this patient having pulmonary embolism features, but also having deep vein thrombosis features. And this is a pregnant patient. You don't want to do a lot of investigation in a pregnant patient, okay? So for this patient, if you can show that this patient having DVT in your Doppler ultrasound, this patient most likely having a PE, okay? So you don't need to do a VQ or CTPA to confirm it. Yeah, this is like Wells criteria more than, like, even I think it's 9. So this is like definitive, you can say. So you just do a Doppler ultrasound and that's all that you need to do for diagnosis. Very important, guys. You need to always read the question properly. Otherwise, you will miss this thing. Let's move on. A patient recently diagnosed with skin infection for which an antibiotic needs to be started. Patient has history of allergic reaction with cefazolin, and he remembered it was not a severe reaction. When it says in the question that it was not a severe reaction, it means it was not a type 1 or an anaphylaxis reaction. So if it's not an anaphylaxis, you can even give cephalosporin to this patient. What you can do for this patient? So this patient having a skin infection, but having an allergic reaction to cefazolin, which is a kind of cephalosporin, right? Now, this patient had a severe reaction to cefazolin, not a severe reaction to cefazolin, but you want to give an antibiotic. What antibiotic you can give for this patient? You want to give cefazolin. You don't want to give cefazolin because patient had an allergic reaction. So you will not give cefazolin, obviously. You want to give any antibiotic other than cephalosporin? Now, the question is cephalosporin contraindicated for this patient? No. Okay. So you can give cephalosporin. You just don't want to give cefazolin, but all other cephalosporin you can give. Why? This is the only cephalosporin in which you can do that. See that cefazolin has no common side chains with other beta-lactam antibiotics. So can often be tolerated in patient with a penicillin or a cephalosporin allergy. So if someone having cefalolin allergy, you can give other cephalosporin. But let's say someone had a cefalexin or cefaclor allergy. These two has similar side chains to amoxicillin. So if someone having a serious history of amoxicillin or ampicillin allergy, you would avoid cefalexin or cefaclor. So that's why I say that cefazolin is a special drug because it doesn't share its side chains with any other antibiotic. So someone having an allergic reaction to cefazolin, that patient should not receive cefazolin, but you can give any other form of antibiotic. So obviously you can give cephalosporin, you can give penicillin, that's fine. Now in this case, you might get confused with why not giving penicillin to this patient. The thing is, like, it's also a correct answer in this case, but you need to also read the question properly. What an examiner is looking into this question, right? So if you are the examiner who made this question, what would you think of? You would think of that, well, let's make a question where everyone will get confused. Obviously, if someone having cefazolin allergy, most of the candidate will think that this patient cannot get any cephalosporin, right? So let's make that an answer. So this is like reading the mind of examiner. That's also important in this sort of MCQs. So you just need to think that what would you do if you were an examiner? Okay, so what you are looking for. So you should obviously look for that if the candidate knows that if someone having a cefazolin allergy, can they take other cephalosporin or not? Okay, so I'm not saying that this penicillin is not a wrong, is a wrong answer. It's also a correct answer. But again, if we think about the question perspective, this is a better option. Okay, so this patient can give any other form of cephalosporin, other cefazolin. If you choose C, it means that this patient cannot take cephalosporin, but this patient can take it. Only cefazolin cannot be given. Okay, clear, guys? There is a very good explanation about this thing in Essay Health. Please go through that in your own time. Next, a difficult appendectomy was done on a patient where a turbid fluid was aspirated and peritoneal cavity was washed with saline. Post-operative catheter for 24 hours, received antibiotic for 3 days in hospital and discharged, and told to continue for 5 more days. Day 6, patient came again to you with fever, abdominal pain, and mild tenderness in the abdomen with intermittent loose stool. Blood pressure is stable, 100/60. What is your diagnosis in this patient? Very important and complicated. So you want to think about deep pelvic abscess, subphrenic abscess, anastomotic leak from stem, bowel perforation. So rule out the unlikely causes first. Whenever you are confused in exam, try to exclude your most unlikely answers. So bowel perforation is most unlikely, right? Why? Because if it's perforation, patient will not have only mild tenderness. So patient will be very sick. Subphrenic abscess always causes very high fever with chills and rigors. That's always a presentation. Fever with chills, abscess. Okay. Now, only fever in here. That's one thing. Deep pelvic abscess or any abdominal abscess after surgery usually occur in 10 to 14 days because it needs time to form an abscess after surgery. Okay, this patient is post-operative day 6. So this doesn't go with this, right? Now you need to think a little bit more than what would you know. Let's move on to this one. So what is anastomotic leak? Means that obviously when someone have a bowel operation, the bowel will be opened and then it will be closed, right? If there is a leak of abdominal contents from a surgical anastomosis, that's called anastomotic leak. Like this. So say that from here, abdominal contents are coming out into the peritoneum. Lots of risk factors can be there. This patient had a difficult operation, remember? So this patient is a high risk of having an anastomotic leak also. The most common clinical feature of an anastomotic leak is abdominal pain and fever, usually present 5 to 7 days. Our patient is post-op 6. So goes with their timeline. Other features can be prolonged ileus or delirium. Patient will be pyrexial, tachycardic, with or without sign of peritonism. What investigation would you do in a patient with anastomotic leak? So if you suspect someone having an anastomotic leak, you should do a CT scan with contrast of abdomen and pelvis. Okay, so if we look again in here, it's a very important thing, and lots of candidates get it wrong also, because we know that pelvic abscess is a common complication after surgery also. But couple of things which doesn't go in this case is this post-operative day 6, usually 2 weeks needed to form a deep abscess after surgery. If you would go, remember, if I don't know, like if you know about that, like post-operative fever, there is an important mnemonic. So always remember, if someone having fever in post-operative day 1, it's most likely atelectasis, or in a layman term, it's just a lung collapse after surgery, you can say. So 24 hours of surgery, someone having fever, atelectasis. Even like 48 hours, you can say atelectasis. When it becomes post-op day 3, it becomes infection. So what infection? UTI or pneumonia. 3 to 5, patient having fever, deep vein thrombosis is your most likely cause. 7, it could be wound infection. Or even sometimes it could be septic thrombophlebitis. 10 to 14 post-op, then it becomes deep abscess. Okay, so this is a well-known complication, and we always follow that in any post-op fever cases. So this patient doesn't go with that, right? So fever, abdominal pain, tenderness, and intermittent loose stool. Loose stool can happen in anastomotic leak also. Okay. So if this patient would come to you at post-op day 10 with the same feature, you would think about deep pelvic abscess. So perforation, we usually use the term perforation when there is features of peritonism is there. Okay. Now, obviously, that leaking can eventually go or complicated with perforation. Okay, but bowel perforation is mainly like, let's say, like someone who had a stomach ulcer or a duodenal ulcer. That patients with, like, naturally as a complication, patient developed some hole in their bowel, okay, or in the stomach or in the duodenum. We call those sort of things as a bowel perforation. Okay, the most important part is like when someone develops severe abdominal pain, okay, like acute onset of severe abdominal pain, and patient cannot even move their abdomen or even cannot move to their right or left side because even a slightest movement causes severe abdominal pain. They are having a board-like rigidity guarding absence of bowel sound, that's the time when we call it as a bowel perforation. Okay, but again, like let's say like a small amount of anastomotic leak, we will not call it as a perforation unless this patient presents with full feature of peritonitis. Clear, Dr. Marco? Next, a 50-year-old patient presents with severe melena. 2 packs of RBC has been given already. Now the patient is stable. Normal colonoscopy and endoscopy. What to do next? So what do you think in here? So a patient who is a 50-year-old having melena. What is melena? It's an upper GIT bleeding, right? If they use the term hematochezia, that becomes a lower GIT bleeding. Important to know this term. So melena means it's a black tarry stool, okay? And that obviously we think about upper GIT bleeding. But obviously we would start with endoscopy first to find out if there is any bleeding from the upper part of the GI tract. If we don't get anything, we will also do a colonoscopy because it could be something from the small gut or large gut also. So colonoscopy we will also do. If both comes normal, then what do you think about it? So what is the term we use if someone has GIT bleeding with both endoscopy and colonoscopy normal? We call it obscured GIT bleeding. That means that we don't know from where the bleeding is coming, right? Now, endoscopy mainly look into the stomach and a little part of the duodenum, whereas colonoscopy mainly look into the large gut or large intestine. So what's left mainly? The small intestine. Sometimes colonoscopy may not look very clearly into that small intestine. So bleeding can come from a small intestine also, right? So if someone's having normal endoscopy, normal colonoscopy, if it's a melena, you can do a repeat endoscopy. That's in a guideline, we can do that because sometimes we can miss it. But repeat colonoscopy has a very limited evidence. Now, you did a repeat endoscopy, that's also normal. Then what you do? Then the next best option for this patient will be a capsule endoscopy. Now, there is a very important guideline about it, which you guys should know because a lot of questions can come from here. If you look at the options, CT angiography, we also do that in some patients with this upper GIT bleeding. Where we do that, if someone's in here, if the patient was unstable and is still bleeding, you would not go for capsule endoscopy, rather you would do a CT angiography because it can show exactly where is the bleeding, okay? So if someone is unstable, if someone is having ongoing bleeding, we would rather go for a CT angiogram. When we do this technetium scan of the red blood cell, anyone? Anyone knows about this technetium scan? When we do that, only one condition in GIT bleeding we do that. If we think it as Meckel's diverticulum, okay? MR enterography, we can do that. CT or MR enterography, both we can do. It's a very good choice of investigation also. But usually if capsule endoscopy comes normal, we would rather go for a CT or MR enterography. Now let's have a look in here. This is also an Australian guideline of imaging in a patient with obscure GIT bleeding. So let's say patient having inactive bleeding. That means at the moment, patient is not bleeding. If you suspect someone having a Meckel's diverticulum, then we do this technetium labeled red blood cell scan. If we don't suspect that, then we think if someone having recurrent overt or occult bleeding, that means if someone having a recurrent melena or any form of GIT bleeding, we can do either capsule endoscopy or CT or MR enterography. But normally, capsule endoscopy will be the first choice of investigation. But there is one condition where you would do CT enterography first in obscure GIT bleeding. Anyone? If you suspect, not unstable, if you suspect that this patient having GIT obstruction, so intestinal obstruction, you would rather go for a CT enterography in that case. Only that's the time you would do a CT enterography first before doing a capsule endoscopy. Okay, in any other case of obscure GIT bleeding, by the term obscure GIT bleeding, you should understand this patient already had endoscopy, colonoscopy, and it's normal. Okay. So in that case, we would start with capsule endoscopy most of the time. If you suspect bowel obstruction, then you can do a CT enterography or MR enterography. Let's say you did a capsule endoscopy that came negative, then you do a CT or MR enterography also. Let's say that's also negative. Is there anything we can do? Yes. We can either talk with the gastroenterologist or we can do a double balloon endoscopy, DBE. Remember these things because question becomes complicated in the exam nowadays. So please remember all these things that I'm talking about. So capsule endoscopy, next is CT enterography or MR enterography. And the last option will be doing a double balloon endoscopy. Okay. All right. So this is how we do the capsule endoscopy. See that this is the capsule patient will intake and it will travel through the esophagus, stomach, the whole part of the gut, and it will come out through the stool. And it has some camera and lens, and it will give a proper imaging of the GI tract. It's a very good one, I would say. So this is the imaging guideline that I have shown to you. There is one another guideline. It's a very, let me show it to you, and please go through that. Look at this one. This is always like when you see 23 pages in a PDF, you don't want to read everything. What you would read? You would read the recommendations. You would read any chart that you can see. Okay. So always this is an easier way to find out what's actually important in that particular PDF. So second look upper endoscopy should be considered in cases of recurrent hematemesis, melena, or previously incomplete exam. So a strong recommendation. But second look colonoscopy usually is not very important. It has a very low level of evidence and conditional recommendation. Even second look upper endoscopy, low level of evidence. So it's not very important to do because most of the time it will come normal. If the second look examinations are normal, then the next step to look for a small bowel evaluation, right? So small bowel evaluation, how we do? Video capsule endoscopy, VCE, is considered as a first-line procedure. If you get a small bowel bleeding suspected and a negative capsule endoscopy, then CT enterography should be performed. CT is preferred over MR imaging for the evaluation of suspected bowel bleeding. Okay, usually you do MR in case of someone who is very young or someone having contraindication for a CT scan. And if you look at the chart, this is the chart I was talking about. Everything that I talked is here. Okay, so you can do a repeat endoscopy if you want, but initially you would do a video capsule endoscopy. If that is positive, you can go for a CT enterography. Let's say someone having massive suspected small bowel bleeding. You stabilize the patient and you can do either red cell scan or CT angiography. I would rather do a CT angiography first, followed by red cell scan, because this is more available. Okay. If you suspect someone having a subacute or acute bowel obstruction with ongoing bleeding, then you can do a CT enterography at that time. Okay, I think there is something in here written like that. Let me show it to you. Okay, I can't find it, but just have a read it in here. There is something written like that. Okay, so give it a read in this guideline. You will be fine. You will find that, because I was reading this one, I found that. So it should be. So these are the things that you would consider when you are finding an obscure bleeding in your exam. Very important, because a lot of questions can be made from this particular topic. Okay, and if you just think about capsule endoscopy and you don't know when to do CT angiogram, when to do technetium scan, when to do CT enterography, then you might miss it in the exam. Okay, that's the reason I say don't memorize answer, because you are just making your own trap. So MR is the magnetic resonance. That means MRI, right? So CT and MRI. Let's move on. So you've got a 35 weeks pregnant patient brought by ambulance after motor vehicle accident. Examination shows normal fetal heart rate, normal blood pressure, and a normal physical exam. What to do next? So you want to do 24-hour bed rest, blood pressure monitoring every 4 hours, fetal heart rate intermittent auscultation every 6 hours, discharge the patient, or doing an ultrasound. So let's say it should be like obstetric ultrasound or abdominal ultrasound, something like that. So when a pregnant patient in this week, it's a 35 weeks. So that means it's like really close to birth or close to delivery, right? Or you can say it's a third trimester. They are high risk of having complications. So if someone having a motor vehicle accident in this week, what is the most important thing that you would like to rule out? Guys? Yes, very good. You want to rule out abruptio placenta. Okay, that's important. Yes, rupture uterus. You want to rule out any fetal-maternal transfusion. Okay, because if it's Rh negative women, this must be a problem. But the most important is is the placental abruption followed by rupture uterus. Now, sometimes initially after a blunt abdominal trauma, patient might be stable, fetus might be stable, but eventually in the ongoing 24 hours, the patient might develop sign and symptom. So you can't discharge this patient even though everything comes normal. You need to monitor this patient at least 4 hours, at least. Okay, this patient cannot go home immediately, never. So, but we don't do BP monitoring. What we should do in this case is we need to do a CTG in here. That's the most important thing. So we need to do a CTG monitoring at least 4 hours. BP monitoring is not important. Obviously, we do that, but most important is CTG. 24-hour bed rest, not very important, but we can give some bed rest like 4-6 hours. Fetal heart rate, intermittent auscultation every 6 hours. Now, we can do that, but how can we exclude abruption or or some bleeding going on in the abdomen. We need to rule that out. That's the thing, okay? It's not only that we will just check intermittent auscultation of the fetal heart rate, and that's all. If we move on to our guideline, then we'll find something important. So let's have a look in here. Abdominal pain and trauma in pregnancy. In trauma in pregnancy, this is a very good guideline. Always remember SA Health is a good guideline for obstetrics. So always go through the SA Health guideline. So once you find out a trauma in pregnancy, you obviously do primary survey and secondary survey looking for any form of injuries. So you do a primary survey, you do the maternal observation, you check fetal heart rate. You should obviously do a CTG if it's more than 26 weeks pregnancy. Once primary survey and CTG is good, you should do a secondary survey also. After that, you do some investigation. So you do laboratory investigation, like you want to rule out any fetal-maternal transfusion by doing a Klaher test. You want to do other, like just a basic blood test also. You want to do imaging, especially the most appropriate imaging will be a first scan. Okay. So first is a bedside ultrasound scan, so which can give you a lot of information about any possible trauma in the abdomen due to the motor vehicle accident. If you look at here, vaginal bleeding present, then what are the things you need to look at? If no vaginal bleeding, then what you should look for if patient having abdominal pain. If patient doesn't have anything, but there is some abdominal trauma due to motor vehicle accident, this is our patient. We consider placental abruption, preterm labor, rupture uterus, fetal-maternal hemorrhage. Okay, in that case, we look for the CTG. CTG and maternal vital will show that if the mother is stable or if the fetus is stable. CTG will show that. So if no problem with the mother or fetus, then you would just do a continuous CTG monitoring for 4 hours. If patient is Rh negative, mother is Rh negative, you give NTD just to make sure that it doesn't cause any Rh so immunization. If everything normal after 4 hours, you can discharge the patient home also. Okay, so imaging is important. So in here, we do the first scan or ultrasound scan. So that's your everything written in here very clearly. You can go through that in your own time. If you look at here, CTG monitoring should be continued for a minimum 4 hours in context of abdominal trauma. This is the most important one. If there is something in the option as a CTG monitoring, you would obviously choose that. So assessment of fetal well-being is important. So you do that by checking, usually going through the CTG actually. The CTG can be done. And then for maternal complication, to detect any intra-abdominal injury, you can do a first abdominal CT or MRI. We try not to do CT scan in a pregnant patient in this time. Okay, either MRI can be done or ultrasound is a very good one which you can do. So a careful ultrasound exam of abdomen, pelvis, and pericardium is the initial investigation of choice. Okay. What are the discharge criteria? If no sign of fetal compromise after 4 hours of initial electronic fetal monitoring, that's the CTG. No uterine activity, that means no uterine contraction, which means it's not a preterm labor. No rupture membrane, so it's not a PROM, premature rupture of membrane. No vaginal bleeding, most likely not a case of abruption, not a case of rupture uterus. And normal ultrasound. Okay, so we need to do all these things. So CTG and ultrasound should be done in this patient. So that will be your investigation of choice. Okay. Next, alcohol-related violence in a community. Asking advice from GP to reduce the violence. Like not a good question for exam, but these questions you can get also, unfortunately. So what do you do as a GP if in your community there is a lot of alcohol-related violence? So you would create an alcohol anonymous group. You would give financial support and psychological support. You are not supposed to give financial support. Okay, it's not needed as part of your GP. Increase police force, not important. Okay, and it's not your job to increase police force, right? Now, between A and D, A is a very good option also, like alcohol anonymous group, but you are not supposed to create that. It should be already there. And there is even online alcohol anonymous. There's like hundreds of alcohol anonymous groups in Australia. You don't need to create one. And it's not your job to create alcohol anonymous group also. But you can increase you can engage those patients with these pamphlets. That means you can educate them. So as a GP, your job is to increase awareness about the alcohol-related complications. So the awareness can be achieved by a lot of things. So you can talk with them. You can make a session in the community. You can just distribute some pamphlet also. Alcohol anonymous group it's a group of people who are all in the same page, like someone who is trying to quit alcohol, but they are not doing very good. You can refer them to this alcohol anonymous group, and they talk with each other, they share their feelings, okay, they support each other, and through lots of discussion and everything, sometimes they can quit alcohol. Because like if you're single-handedly trying to quit something which is addictive, it might be hard. But if you can see like 10 people in the same page like you having a same issue, you will feel supported, like, and you will feel comfort. That's the job of alcohol anonymous group. And no one knows their name and anything. So that's totally anonymous also. So best option would be a distribution of pamphlets in case of a GP job. Next, easy question. A 3-year-old patient presents with fever, cough, vomiting, abdominal pain. Normal chest auscultation, very important clue. What could be the possible organism? To understand the organism, you need to know the diagnosis first. So 3-year-old child having fever, cough, vomiting, abdominal pain. What you are thinking about? What's your diagnosis? Looking at the option, you should already know that it should be a case of pneumonia. But what type of pneumonia? Always remember, if a child has features of pneumonia, which is fever and cough, vomiting also can be a feature of pneumonia. Even abdominal pain can be a feature of pneumonia in child. Okay. Now the question is how we know it. The thing is the symptoms doesn't correlate with the chest examination. That means you see the chest examination is totally normal. And that's how we know that this is most likely a case of atypical pneumonia. So in atypical pneumonia, there will be features of pneumonia, but chest examination will be normal or very minimal. But if it was a case of bacterial pneumonia, in the chest examination, you would get reduced breath sound at least. Okay, that means features of consolidation should be there in a chest X-ray or in a chest examination if it's a bacterial pneumonia. So it's not a bacterial pneumonia. So it's not, let's say it's not Streptococcus pneumoniae, which is the most common cause of bacterial pneumonia. Streptococcus pyogenes, not likely. Haemophilus, not likely. Staph aureus, very uncommon to cause pneumonia. But atypical pneumonia, the most common cause is mycoplasma. Okay, you guys are right. Very good. So mycoplasma usually comes in this way, like fever, dry cough, sometimes even abdominal pain, but chest examination will be normal. If you do a chest X-ray in this patient, you would get some interstitial infiltration, like a kind of whitish shadow all over the lungs, but no sign of consolidation. So mycoplasma is the commonest cause of atypical pneumonia, I would say. But Streptococcus pneumoniae is commonest cause of bacterial pneumonia. And if someone asks you what is the commonest cause of pneumonia in a child, that's also Streptococcus pneumonia. Now, because I came into pneumonia, I guess let's just discuss a little bit about pneumonia investigation and management, because that's super important for your exam. So, pneumonia in children, what actually we should know about it. So pneumonia in children can be due to bacterial pneumonia, can be due to atypical pneumonia or viral pneumonia, right? Now, bacterial pneumonia is the most important one because that's more complicated and it causes, sometimes it can be a life-threatening or even very severe form of pneumonia in a child. In a child who develops bacterial pneumonia, do we need to do chest X-ray in every children or not? Let's discuss it over RCH guideline. So community acquired pneumonia, RCH is very good for your pediatrics. So please focus on that for every pediatric topic. Look at here key points. You can diagnose pneumonia clinically. Chest X-ray is not required for a routine diagnosis or management unless you suspect a severe or complicated pneumonia. So we need to know when we suspect severe pneumonia and what is complicated pneumonia. We'll come into that. Blood test and microbiological investigations are not recommended for routine use in diagnosis and management of community-acquired pneumonia. That means you don't need to do a full blood count, you don't need to do a blood culture or even a viral swab in a patient of suspected pneumonia, not for every patient. For non-severe pneumonia, you can just diagnose clinically and you can give oral amoxicillin. But if a child develops any features of pneumonia and it's a less than 1 month old child, that means it's an infant, that patient should be treated as a sepsis. Okay, that means as a complicated form. How we know it's a pneumonia? Usually child will present to you with fever, cough, and shortness of breath. When we call it complicated pneumonia, when pneumonia patient develops parapneumonic effusion or empyema or lung abscess. These are called complicated form of pneumonia. So all these are features: fever, fasting breathing, that means very increased respiratory rate, cough with sputum production, sometimes even apnea. In examination, you might get increased chest wall indrawing, intercostal recessions, grunting, nasal flaring. And if it's a consolidation, you will get decreased breathing with a bronchial breathing or auscultation. And even sometimes you can get an absent breath sound. Severity. When we suspect severe form of pneumonia, you suspect severe pneumonia if there are clinical features of pneumonia and one or more of these features. So severe respiratory distress. So when we call it severe respiratory distress, these are the form, that means someone having intercostal, suprasternal, or costal margin retraction, nasal, that means use of accessory muscles. Okay, that's severe respiratory distress and also increased respiratory rate in terms of age group. severe hypoxemia, that means their oxygen saturation is less than 92, cyanosis, marked tachycardia, altered mental status, like child is drowsy, empyema. These are the features of severe pneumonia. Okay. Also, if someone having parapneumonic effusion, that's a severe pneumonia as well. Routinely, you don't just do chest X-ray to diagnose community-acquired pneumonia, but if you suspect it's a severe pneumonia, you have to do a chest X-ray. Okay. So, and also, let's say you started antibiotic, oral amoxicillin, by thinking that this is a mild pneumonia or non-severe pneumonia, and that patient did not improve in 48 to 72 hours, that's also most likely going to be a complicated pneumonia. So you do a chest X-ray then. Other than that, it's important to do blood culture. If it's a severe or you think that this is a complicated pneumonia, you should do a blood culture. Okay. Especially for a child who is having fever more than 38, we would do a blood culture. Treatment. So first thing that you look for, that if it's a non-severe pneumonia or it's a severe pneumonia. So what are the severe pneumonia? Severe respiratory distress, hypoxia, tachycardia, altered mental status, empyema. You need to look for this in the exam questions. If you get at least one of it, that's a severe pneumonia. For someone who is having severe pneumonia, you need to admit the patient, you need to do a chest X-ray, blood culture, and start IV antibiotic. So child with features of severe pneumonia, hospital admission is obvious, and you give IV ceftriaxone and IV flucloxacillin. Okay. Sometimes if you suspect MRSA, methicillin-resistant Staph aureus, then you need to add vancomycin also. So, but mainly we give ceftriaxone plus fluclox, and that's for severe pneumonia. Now, let's say child is not having severe respiratory distress, no features of severity, then you think it as a non-severe pneumonia, and you can treat it as an outpatient oral antibiotic, which is amoxicillin, for 3 to 5 days. Now, in non-severe pneumonia, you might need to give IV antibiotic, especially IV benzyl penicillin, when if you see in the question, this child is unable to tolerate oral intake or child is actually vomiting. When child is vomiting or not feeding, you can't give oral antibiotic, you have to give IV benzyl penicillin. Okay, so very important, whatever I'm saying, everything will be important for exam. Now, let's say we have found a child who we started antibiotic, but after 48 hours, still having high fever and getting worse. So now you're thinking that it's a complicated pneumonia. What would you do next? Guys? So you started antibiotic, oral antibiotic in a child you suspect pneumonia as a non-severe pneumonia, and you started oral antibiotic, amoxicillin, send the patient home, but 2 days later, child presents with the father with increasing shortness of breath or high fever. What you are thinking? You are thinking complicated pneumonia. So what do you do next? You do a chest X-ray, you do a blood culture. Okay, if patient having very high fever, you should do a blood culture also. But start with a chest X-ray followed by blood culture. Now, after blood culture, what would you do? You should always start IV antibiotic for that patient. Obviously, admission is first, okay? But so you did a chest X-ray, you taken blood culture. You don't start IV antibiotic or any form of antibiotic before doing a blood culture. Okay, so you do a blood culture first, and you don't need to wait for the culture result. You just send it to the lab, because lab can take 3 to 5 days. So why you do that? Because sometimes after giving antibiotic, you might not be even able to find out the specific organism which caused it. Okay, so that's very important. You always send the blood culture to the lab and then start with antibiotic, especially for this sort of complicated pneumonia. But for mild pneumonia, you don't need to do a blood culture. Okay, well, you did a blood culture, you started IV antibiotic, and in the chest X-ray, you find out that patient having fluid in the X-ray. So once you know that this patient having fluid, it can be due to empyema, or mainly most likely it's a parapneumonic effusion. So what you can do to quantify the amount of fluid in the lung, you need to do a chest ultrasound. Okay, if it is a small amount of fluid and the child is not having severe shortness of breath, and after giving antibiotic, child is getting well, you just continue the antibiotic. You don't need to do anything else. But you find out in the chest ultrasound that child having a large amount of pleural fluid, and that's also causing moderate or severe respiratory distress. Then you can't just give antibiotic, you need to drain that fluid. Can you drain that? No. In Australia, you would never ever touch this child. Okay, you have to refer this patient to a pediatrician who is like a respiratory pediatrician. Respiratory pediatrician can go for either video-assisted thoracoscopic, I think it's a video-assisted thoracoscopic surgery, something like that. So they can do a VATS, or most of the time they would go for a percutaneous, a small bore chest drain insertion. Okay, so they can do a chest drain. You will not do that. So lots of important things to understand about it. Okay, do you guys understand what I am saying? Good. Now let's say we have got a child, 2-year-old child. Okay, so let me give you a scenario. 2-year-old child having respiratory rate 50, heart rate 120, saturation is, it's a heart rate 90. Okay, child having shortness of breath and fever, also some cough. Okay, so what is, okay, on the top of that, child also having vomiting and abdominal pain. Okay, and this fever is very high fever. Let's say 39. 39 fever usually doesn't occur in viral or atypical pneumonia. It's usually bacterial pneumonia we should think about at that time. What do you want to do in this patient, in this child, or what is your most appropriate management? So let's say 2-year-old child having shortness of breath, fever, high fever and cough, having vomiting. Heart rate is not very high. Respiratory rate is 50. Now respiratory rate 50, okay, but is it a non-severe or severe pneumonia? Why it's severe? This patient having shortness of breath. Now, for a 2-year-old, what's the normal respiratory rate? Yeah, so 25 to 30, you can say. So this child is obviously having increased respiratory rate. 50 is very high. So this is important. Now, they told you that if it is only any of any of the features is there. Now, this patient having respiratory distress. So this is a severe form of pneumonia. For severe form of pneumonia, you would look for doing a blood culture. If the investigation comes, then they would give you full blood count, blood culture, chest x-ray, everything. Usually what you should do, you should start with a blood culture because of high fever. First blood culture and then send the child for an x-ray. Okay, and also start antibiotic as soon as possible, IV antibiotic. Let's say if this was a respiratory rate of 20, what antibiotic you would give to this child? Child having vomiting, can we give amoxicillin? We don't need to give ceftriaxone in a non-severe pneumonia. What we can give? Yes, benzyl penicillin, guys, right? So that's the important thing. See that this is the smallest thing. If you don't know, you will miss it obviously in the exam. So a child having vomiting, you don't give oral antibiotic because they will just vomit it out. It will not work. Okay, so you give benzyl penicillin for that child. Cool, you guys really learning a lot. It's good. Okay. All right. Now let's take a 10-minute break and then we'll start again. Are you guys enjoying the class? All right, let's take a 10-minute break, guys. Thank you all. All right, everyone. Let's start again. Hang on a second, please. Those who are in the Facebook, you guys can write any questions that you want to ask in the comment section. Okay, I'll have a look later on. So 18-year-old male, previously normal pre-employment urinary exam. Okay, so before employment, this patient had an urinary exam and that was normal. Today you did a urine dipstick which showed 1+ protein in the urine. Then you did a 24-hour urinary protein test and you found that there is 200 milligram per day of protein. Normal value is 150. So obviously there is some protein is coming out, or you got some increased amount of protein in the urine. You did a repeat morning dipstick, which came negative, but you did again in afternoon, that's positive. So what's going on with this patient? What do you think is the most likely cause of proteinuria in this patient? It's a young patient, very unlikely to develop some renal failure, right? Unless this patient having any polycystic kidney disease or any other congenital problem. Okay, but nothing else we can find out. So let's not think about anything like a renal failure or very severe form of condition in an 18-year-old. We don't know about the exercise. It could be exercise-induced proteinuria, but why the afternoon one is elevated, but not the morning one? But again, like we don't think about excessive exercise unless it's given in the question. So you want to give some advice to the patient. You want to reassure, you want to increase dietary protein. Why? Because you want more urine to come out, decrease dietary protein. Is the protein, like anything is written about the diet in this patient in this question? No. Refer to nephrologist. The question is what we are thinking about in someone whose 24-hour urinary protein is increased, but morning dipstick is totally negative of protein and afternoon is positive. And 200 milligram per day, is it very high? No. Usually if someone having like more than 1 gram or 2 gram per day, that's a high amount of protein in urine. 200 is not very high. Okay. Now, this is most likely, we will call it as the orthostatic proteinuria. So what is that? Let's have a look. Lots of guidelines are given in here. Please go through that in your own time. Let's have a look first to the Wikipedia. What is orthostatic albuminuria, or what is orthostatic proteinuria? It's a benign condition, occurs due to change in renal hemodynamics, usually occur in normal individuals, causing protein, mostly albumin, to appear in urine when they are in a standing position. Urine formed when patients are lying down is protein-free. That is, the morning urine that you are getting is like patient is lying, right? So obviously patient is sleeping at night in lying down position, not in upright position. So during that time in the morning, if you do check the protein, you will get negative protein in the urine. There is normal urinary protein excretion during the night, but increased excretion during the day, usually increased with activity and upright posture. Because obviously during the daytime, unless you are very lazy or you are very like critically or terminally ill, you will stand and you will do your work. Total urinary protein excretion may be elevated, but levels above 1 gram are more likely to be associated with underlying renal disease. So in this patient, what you would get that the morning urine will be normal, no protein in the morning urine dipstick, but in the afternoon, you will get some protein excreted. So because in the afternoon there is some protein, the total 24-hour urinary protein will be a little bit elevated, but obviously it's a very small amount of elevated protein in the urine, not more than 1 gram. If you get more than 1 gram protein in the urine, that's obviously something is going on rather than some orthostatic transient or exercise-induced proteinuria. Okay, so 200 milligram, not very high. So that if the diagnosis come in here, we would talk it as a case of orthostatic proteinuria. Good guideline in here is this AFP guideline also. So go through this guideline. It's a very good one. So someone who is having urine dipstick saying that patient having urinary protein, what is your next test you would do? Comes in exam very frequently. So you did one urine dipstick, it came as proteinuria, 1+, 2+. What is your next test? And let's say kidney function, everything is normal also. So have a look in here. This is the evaluation of proteinuria. Please remember that in your exam. Let's say you did urine analysis, okay, and you got it negative. The important part is that let's say you can get either two. So one you can get is that trace to 2+ protein in dipstick, or maybe you send the urine to the lab for urine microscopy and analysis, you got some proteinuria. Okay, so if you get dipstick proteinuria positive, you can't just say that this is confirmatory, because there are some benign causes of proteinuria also. Like sometimes it could be just a transient proteinuria. Sometimes patient doing a lot of exercise can present with proteinuria. So you want to rule that out. So you did a repeat urine analysis at least 2 to 3 times. Okay. Once you did repeat urine analysis and still it is positive, then you do the quantification of proteinuria. That means you do a 24-hour urinary protein collection, or you do a urine protein creatinine ratio. Which one is more diagnostic, or which one you would do? If you got 2 of these options in your question, one is urine protein creatinine ratio and another is 24-hour urinary protein collection. Which one is more feasible and which one is most appropriate? No, it's urinary protein creatinine ratio. That's the best one. Okay, you would do that one. But again, you can do 24-hour urine also. But in between these two, this is the best. Now, let's say you did that and total urinary protein is less than 2 grams per day. So you did a 24-hour urinary excretion and that becomes less than 2 grams. Then you just check the kidney function. That means you did a creatinine clearance and also kidney function. If that is normal and the age is less than 30, you think about orthostatic proteinuria. So you do the workup for orthostatic proteinuria. How you do that? You check urine in the morning, you check urine in the afternoon. If morning urine doesn't show any protein, but afternoon urine shows protein, that's your orthostatic proteinuria. Then you just reassure and you do an annual blood pressure and urine analysis. If age is not less than 30, okay, then it could be just an isolated proteinuria also, the same thing. Okay, nothing abnormal about it. You cannot diagnose isolated proteinuria unless you rule out orthostatic proteinuria. Okay. If patient kidney function is reduced, then you need to think about any underlying condition. That means you do further kidney-related investigations and talk to the nephrologist. Okay, so this is exactly what you need to remember. It's very important. You get 1 or 2+ protein on dipstick, immediately you start doing all the investigation. That's not right. Okay, you do a repeat test first, confirm it, then you do all other investigations. So for this patient, we already did everything, and you can see in here, this is an orthostatic proteinuria. You can just reassure the patient, nothing else. You don't need to do anything. Clear? Next question. A 13 weeks pregnant patient presents to your GP clinic. She is complaining, feeling anxious and worried about the pregnancy all the time. It became so severe that it's consuming most of her time these days. She has previous history of anxiety in college. Then she became normal. Once she became pregnant, anxiety symptoms reappeared. What can be the cause? So you can find out that this is a pregnant patient and she's mainly anxious and worried about pregnancy all the time, and it's very severe. So do you think it's a pregnancy, a specific anxiety, panic disorder relapse, normal pregnancy, generalized anxiety disorder? Anyone? So let me tell you that this is called pregnancy-specific anxiety disorder. How we know that, how we rule this out? Now, it could be normal pregnancy, but again, something consuming most of the time, okay, that's not normal. Okay, so don't think it's normal. So like every pregnant woman will be a little bit of anxious. That's fine. But if it's consuming every time, that's not normal. Now, you might get into the trap that patient had a previous history of anxiety in college, and you can think about panic disorder relapse. What is panic disorder? So it's a whole new topic for you. We would discuss it in psychiatry, but giving you an idea is that panic disorder is having recurrent panic attack and patient thinking about their next panic attack. And that's why they stopped going into crowded places or confined spaces. Okay, that's called panic disorder. That means patient has to have recurrent panic attack. What is panic attack? It's a very transient episodes of feeling severe anxiety, chest pain, shortness of breath, choking sensation, smothering sensations, sweating, trembling, or you can say even feeling perioral numbness. Okay, all these features, which is usually like 10 to 15 minutes in duration, and then it becomes really normal. That's panic attack. Someone having recurrent panic attack like this, they starts to worry about the next attack. Okay, and that's why they stop going outside. When they are worried about next attack, it is known as panic disorder. And those transient episode of symptom patient is getting, that's panic attack. Okay, so recurrent panic attack equal to panic disorder. When a panic disorder patient stop going outside or crowded places, that is known as panic disorder with agoraphobia. None of these things are here, right? Patient is only anxious and worried about pregnancy. So it's a pregnancy-specific anxiety. Why it's not generalized anxiety disorder? Because generalized anxiety disorder patient worries about everything. Like you are walking in front of the patient, and that generalized anxiety disorder patient will be worried about you. Okay, like a normal person is not worried about everything, but generalized anxiety disorder patient is worried about everything. Okay, so that's the one thing. And here they have told you that patient is worried about pregnancy all the time, not about all the things. Okay, so it's a pregnancy-specific anxiety disorder. And yes, Dr. Saida, that's also important. 6-month duration is needed to diagnose generalized anxiety disorder. Okay, so that's your diagnosis, pregnancy-specific anxiety. So pregnancy-specific anxiety is defined as a mental state of a pregnant woman whose concerns are specific to the pregnancy itself, such as fears regarding the pregnancy, delivery, and health of the child. It's a very common one. Next, 6-year-old child, previously normal, brought by father to your GP clinic. Child is having difficulty climbing stairs. On examination, there is absence of ankle reflex, decreased power on cough, normal tone, normal CK. There is no facial dysmorphic features. What could be the most likely diagnosis? I know this is very hard for you. Even the options are very hard for you, right? Now let's find out what they're talking about. This DMD, what is DMD, guys? This is called Duchenne muscular dystrophy. Very commonly asked in exam. Another is glycogen storage disorder. What is SMA? Spinal muscular atrophy. Also very important for exam. And botulinum toxin. So in this case, what we should think about, like a lot of complicated things in here, like even a pediatrician has to think about it. So 6-year-old child, previously normal. Okay, the previously normal means that the child was normal previously, maybe. Child is having difficulty climbing stairs. Someone having difficulty climbing stairs. When we climb stairs or when we go upward positions, okay, we usually use our proximal muscles of the hip, right? So that means in here, proximal muscles of the hip is not working properly or weak, right? Absence of ankle reflex, decreased power on cuff, normal tone, normal CK. This is one of the things which would give you some suspicion about choosing DMD in your diagnosis, because CK should not be normal in a DMD child. It's always elevated. Okay. So this is where you should think about, well, can it be something else? Okay. And then you will find it out. There is no facial dysmorphic features. There is a condition called SMA, spinal muscular atrophy, which doesn't involve facial muscles, but it involves every other muscles in the body. Okay. Same with botulinum. Botulinum affects every muscles, including facial muscles. Same with Prader-Willi syndrome, PWS, very commonly asked in exam also. It also involves all other muscles, including facial muscle. But SMA doesn't involve facial muscles. Okay. And child usually is very bright child, no intellectual disabilities in here. Whereas in PWS, child will have intellectual disability. Okay. Prader-Willi syndrome. Now come to the two important conditions, which is DMD and SMA. Let's discuss these two things and then come back. So what is SMA? It's a common genetic disease caused by autosomal recessive mutation in the motor neuron gene. So if motor neuron is affected, obviously it will cause progressive motor weakness and some other weakness as well. Diagnosis made by DNA analysis, that means genetic studies and muscle biopsies. Is the most common genetic disease resulting in death during childhood. That means like SMA has a lot of subtypes. One of the subtype, which is the subtype 1, is very severe form of SMA, and child can usually die within few days. Progressive weakness start proximally and moves distally. Okay, so that's important. Usually the proximal muscle will be weaker in here more than the distal muscle. Pathophysiology, progressive loss of alpha motor neuron in the anterior horn of the spinal cord. That means motor neuron is involved in here, and this is an autosomal recessive one. What are the orthopedic manifestation you can get? Hip dislocation, scoliosis, contractures. Remember, I talked about the subtypes. There are mainly 3 types, each of their own name. You don't need to remember that. Type 1 usually present before 6 months. And in type 1, you can get absent tendon reflexes, fasciculations. Usually child die by 2 years' time. Prognosis is very poor in here. Type 3, it's a normal life expectancy. That means prognosis is not bad. Present at 2 to 15 years. Proximal muscle weakness is the main feature. In type 3, usually like tendon reflex will be intact, everything will be intact. But weakness will be there, like muscle weakness is the prominent feature in here. So symmetric progressive weakness that is more profound in the lower extremity than upper extremity. That means your calf muscles, knee muscles, hip muscles will be weaker mainly, and more profound proximally. How you distinguish Duchenne muscular atrophy from spinal muscular atrophy? So Duchenne muscular dystrophy, usually tendon reflex can be positive. Okay, like can be present. In DMD, usually DTR are present, whereas in SMA child, there will be absence of deep tendon reflexes. On examination, absent ankle reflex. So if you know that, immediately you think about SMA, right? You will not think about DMD. See that knowing the theory is how important it is. And you can get fasciculations also. Diagnosis, best diagnosis would be DNA analysis or muscle biopsy. Any of these two is good. All right, so that's your spinal muscular atrophy. Spinal muscular atrophy can present in a infant also. Like usually child will have poor sucking, they will have like muscle weakness everywhere, child will have floppy limbs, okay, hypotonia. All this can be there in a SMA child. Like it's a type 1 child who is very severe form, but again their facial muscles will be intact. Okay, so that's your SMA in here. Now for Duchenne muscular dystrophy, if we go through that very quickly, DMD is also similar kind of disease. That's why it gets complicated. There will be progressive proximal muscle weakness in here. Similar DMD is called Becker muscular dystrophy, which is a less severe form. It's a X-linked recessive condition, whereas your SMA is a autosomal recessive condition. The main problem in here is the genetic mutation of a protein known as dystrophin. And this dystrophin is found in the muscle cell membrane. So if the muscle cell membrane protein is deficient or abnormal, obviously they will have muscle problem. So patient or child usually have weakness in their hip girdle, shoulder girdle. They have walking problem. Okay, usually delayed onset of walking in a child, you should think about DMDs. They have a difficulty standing and climbing steps. So they usually can't use their hip muscle to stand. So they usually use their hand to stand up. And that has a name called Gower sign. I will show it to you. And they also have difficulty climbing stairs because of their hip muscles are weak. Because hip muscles are weak, they use their calf muscles more, and they can have a hypertrophy of the calf muscles. They have intellectual or learning disabilities. Also, most of them die by the age of 25. If we go through med bullets and go through the DMD, so see that this is called Gower sign. They use their hand to stand up. Look, if you look, a child is standing up in this way, you should immediately think about DMDs. So it's a skeletal muscle disorder also present with progressive muscle weakness. Male children are mainly affected. So you don't think about DMD in a girl. That's also important clue because this is an X-linked recessive disorder, which usually present in a boy, not a girl. Okay, always remember these things because these things give you a diagnosis in exam. Most likely cause of death in a DMD child is respiratory failure or heart failure. So progressive muscle weakness, that's the feature. Gower sign will be positive. Cough, pseudo hypertrophy will be there. Now, DMD usually doesn't cause hyporeflexia. Usually their reflex is present, but sometimes reflex can be absent also. But important finding that CK will be elevated always. Gold standard is genetic analysis. If genetic analysis is negative, then you can do a muscle biopsy. Here, guys, so the thing is, if CK normal, all right, CK normal and absent ankle reflex and progressive muscle weakness, especially the distal muscles and proximal muscles, you think about SMA. If CK is elevated, you think about DMDs. Any question? Now, glycogen storage disorder, you don't need to remember this one. This is also a genetic disorder, which is manifested by excessive accumulation of glycogen in the liver and other part of the body. Your body is supposed to break down glycogen into glucose to use it. Okay. Now, patient with glycogen storage disorder, they can't break down this glycogen and form glucose. Because glucose is deficient, child will be weak. So they will also have decreased muscle tone. They will have weakness in the muscle. Because of low glucose, they will have features of hypoglycemia. And because glycogen is accumulating in the liver, they will have enlarged liver. So the very severely enlarged liver will be there in this case. So this child usually present with hypoglycemia, increased or enlarged liver, and sometimes even enlarged kidneys. They can have muscle weakness. They can have diminished muscle tone also. Okay, not very, very important. Never seem to come in exam, but if you're interested, go through this guideline about glycogen storage disease. But you just need to remember that this part, nothing else. We'll discuss botulinum toxin, how it present in another question. So what's your diagnosis in here is SMA. I know this is little hard for you guys, but is this understandable? Did you understand what I said? How to differentiate between DMD and SMA? Good. Next question. A 41-year-old female with a known PCOS, so polycystic ovarian syndrome, advised regular follow-up of metabolic complications. What is your most appropriate lab work for this patient? LFTs, ultrasound, testosterone, fasting blood sugar, OGTT. So polycystic ovarian syndrome, it's a very common condition, comes in exam frequently. Patient with PCOS, they have more than 10 ovarian follicles, and that can lead to a lot of problems, especially presents with oligomenorrhea or irregular menstruation. Not only that, patient with PCOS have a lot of other complications. So obesity is very important in these patients. So there tends to be obese patients. They can have increased testosterone in their body, leading to acne, hirsutism. And these patients tend to develop lots of metabolic complications, especially they are high risk to develop hyperlipidemia, okay, or hypercholesterolemia. So lipid profile should be done in these patients. They are also increased risk of developing ischemic heart disease or any cardiovascular complications, and most importantly, diabetes. Now, this sort of patient needs regular follow-up of these metabolic complications. So how you do that? You don't need to do liver function test or ultrasound or testosterone. This is what you do in case of investigations to diagnose it. But to follow up, if you want to follow up someone for diabetes, you don't need to do fasting blood sugar. You need to do a OGTT in this case, because this gives the appropriate diagnosis. If you look at the RACGP guideline, you can see in here what are the screening recommendations. So you need to assess their BMI, because these patients tends to be overweight, and the part of the management of PCOS is managing their body weight. Okay, so BMI should be assessed every time you see this patient. Measure lipid profile every 2 years. Okay. Measure blood pressure annually. Assess for diabetes and pre-diabetes. National guideline recommends an OGTT every 2 years in all women and every year in those with additional risk of diabetes. So you need to do a OGTT. This is controversial, but if measuring fasting glucose only, up to 80% of pre-diabetes and 50% diabetes in young women with PCOS will be missed. So that's why fasting blood sugar is not a very good one. But in your option, if you don't get OGTT, only fasting blood sugar, then you have to choose that, right? You don't have any best option there. So you look for all these things. You look for lipid profile, you look for OGTT. Now, because it came into PCOS, some of the important things that I want to ask you is that, let's say you got a patient with PCOS, all the features like a 30-year-old patient coming to you with irregular period, oligomenorrhea, okay, and also having infertility or subfertility. What is your next investigation in this patient to diagnose? Always remember, if you want to diagnose a patient for PCOS, especially for young patient, ultrasound will not give you the most appropriate one. That's one of the important things. If you want to diagnose, you have to do testosterone. I know this is one of the controversial things, but the guideline says that ultrasound can be normal in young patient with PCOS. Okay, so you can miss it, but PCOS patient will always have increased testosterone. So if they ask you what is the most appropriate investigation or even next investigation, we would rather do a testosterone. With testosterone, ultrasound will be an addition, and it can confirm, like it can give you an additional diagnosis. When we say polycystic ovarian syndrome, usually more than 10 cysts should be there to diagnose PCOS in one ovary. If only 1 or 2 cysts in the ovary, can we say polycystic ovarian syndrome? No, at least more than 10 should be there. So if they ask you that if in case of PCOS, always choose testosterone as a next or best investigation. If testosterone is not in the option, then we would do an abdominal ultrasound, or transvaginal ultrasound would be the best one. Sometimes they also can give you a feature of FSH-LH ratio. In a normal person, FSH-LH ratio should be 3:1. When it becomes vice versa, that means FSH-LH ratio becomes 1:3, this is an indication of PCOS. So sometimes you might not get much features, but they might give you a lab test showing this ratio of FSH-LH. Okay, so then you should think about PCOS also. So these are the main investigation for PCOS initially. How to manage it? What is the initial management for a patient with PCOS with no subfertility? So how we manage PCOS patient? We manage it by first 3 to 6 months, it should be a lifestyle modification. So weight reduction is the most important part. And even with just like a little bit of weight reduction, everything can become normal. So you don't need to give medication for every PCOS patient initially. So first 6 months, you do a lifestyle modification, did not improve. What do? Now, then you look at what is the most important symptom in this patient. Is this patient overweight? If this patient is overweight, then what you would do? Then you can give metformin to the patient, because metformin will lose body weight. Let's say this patient, his main problem is having acne or hirsutism. What would you do? You would give OCP. Okay, oral contraceptive pill, also a good idea for a patient with PCOS, especially for someone having acne or hirsutism. Best treatment for hirsutism would be laser treatment, but that's very expensive. Okay, sometimes even OCP can help. Yes, Diane 35. And let's say patient having subfertility with PCOS. Subfertility with PCOS, how you would treat this patient? Yes, clomiphene citrate is the best treatment for that particular patient. Let's say clomiphene is not there. What else we can give this patient? You can give metformin. Okay, so metformin also tends to increase chances of fertility. So, but if both clomiphene citrate and metformin in the option, you would obviously choose clomiphene citrate. Let's say the patient is 40-year-old and main presentation is, let's say the main presentation is subfertility, and it's a 40-year-old. What would you do? Anyone? So usually we can do a procedure called laparoscopic ovarian drilling. Sometimes laparoscopic ovarian drilling can trigger ovulation in these women. Okay, and that's usually like, it's not like always we do, because it's a 40-year-old, we can't wait for medication to start working, right? So in these patients, we want to either we go for artificial reproductive techniques, or we go for this one, laparoscopic ovarian drilling. Okay. Next, a young patient presents with a small soft testis with agiospermia. Which investigation to diagnose? Very easy. So any young patient coming to you with small testes with agiospermia, you think about a condition called Klinefelter syndrome. And the diagnosis is by karyotyping or chromosome analysis. Go through this one, RSCGP and in here. Next question, a 35 weeks pregnant patient presents with dysuria and increased urinary frequency. History of allergy with diflucloxacillin. What is your next most appropriate management? So what antibiotic you can give in a 35 weeks pregnant patient, and looking at the symptoms, it's UTI, right? Dysuria, increased frequency. So what do you want to give? You want to give trimethoprim, amoxicillin, nitrofurantoin, gentamicin, ceftriaxone. We should never ever give ceftriaxone in this patient, first of all, because this is just a cystitis. For cystitis, we don't give ceftriaxone. Forget about it. Even not gentamicin. We don't give trimethoprim in pregnant patient. So what else? If there was a cefalexin in the option, that would be the best one, but that's not in the option. So we have amoxicillin and nitrofurantoin. Let's have a look. This is your JM 6th edition, and it has this guideline. So acute cystitis means patient will have only dysuria and increased urinary frequency. We can use cefalexin, that's the best one. Amoxiclav can be used. Nitrofurantoin can be used. Now, when we use nitrofurantoin, this is the important part where you missed it. 35 weeks patient, and you choose nitrofurantoin, which is contraindicated in the 3rd trimester because it can cause hemolytic disease in the newborn. Do you want to give it? No. So amoxicillin sometimes we can give if we get susceptibility of the organism. But the thing is, in the option, you don't have any best option rather than amoxicillin. So what you choose? You choose this one. I know this is what happens in exam also, because the most appropriate one would be cefalexin, but that's not in the option. So what you would do, you will say that, no, I will not answer this question because most appropriate one is not here. No, you have to choose something. So then you choose the best one out of these 5. Nitrofurantoin can be given if this was let's say it's a 20 weeks patient, then we could give it. But 35 weeks is a 3rd trimester, we would not go for nitrofurantoin. Clear? Okay, so lots of things to learn, right? We know a lot of things, but when it comes in the question, we miss things because there is no one to show you that, well, we need to look at these things. Okay, now you know. All right, I think that we will stop it here tonight. Now, because this is the last 2 weeks free session, what I would just go through that, I just want to go through about the course. And I know like most of you are here who has already joined the sessions and joined the course. But if any of you who has any questions regarding the classes and regarding the course, feel free to ask it here. And I'll show you the video of the course, like the course, which I have shown in the first class, I think. So let's just have a look. I'll try to finish it very quickly. So let's have a look to the video. And then after that, if you guys have any question, feel free to ask me. Okay, I'll be here for a few minutes. All right, guys, thank you so much for being with me. Okay, so any questions? So I think like what's happening in here, like if you guys are not getting any answer for today or day before today, that's because that our information and query team, who is usually supposed to answer your questions and everything, they are offline at the moment for 3 more days. Okay, so because I'm actually doing my work most of the time, I might not get all the time to answer questions. So don't worry, like if you send us an email, it will be answered. Okay, I'll try my best to answer it, but again, like usually it will take some time. We'll increase the time of admission because of this problem. So the team will return on 15th. So during this 3 days time, you might not get answer promptly, so please keep patience and wait for our answers. Okay, in case you miss the classes, you will obviously get a recording in the software and you can go through that. There are 3 classes in a week. 2 classes are mainly theory based, and sometimes also question solvation will be there like this. And 1 class is always for question solvation. Okay. Usually the question solvation classes will be taken by another doctor also, who usually pass recent exam. Usually they take the classes for recent question solvations. Okay, and they're tremendously helpful for every one of you. Okay, and they usually take it on Thursday. Okay, and apart from Thursday, my classes will be on Sunday and Tuesday. Okay, and also you might be like those of you already joined, you know the class schedules. It's not, oh yes, it's not been given or updated yet, but it will be updated tomorrow. You should be able to see the class schedule of this month by tomorrow. So you will get it. The classes are supposed to happen on Sunday, Tuesday, and Thursday. Okay. So the next class will be on Tuesday. That means on 14th. And you should be able to get all the schedule by tomorrow. For those of you who hasn't joined the course yet, okay, but you want to join, then just give me a message in my messenger that you want to join the next class. Okay, in that case, I will just give you the class Zoom ID and password so that you can join. All right, and that's totally fine. As long as you confirm that you want to join, that should be okay. Because it takes some time to give you all the access and everything in the software and in the course. So if you want to continue, just send a message that you want to continue and you want to make payment. In that case, you will get a class Zoom ID and passcode. Okay. And Dr. Edward, as I say that the software and everything is actually, the access are given by the team. I usually don't give it, and it's not my job also. So you might need to wait for 3 days. Okay. So in this time, you can just go through our YouTube recorded videos. Okay, lots of classes are there if you want. Or what's your Facebook name? I can try. I forgot even like when I logged into the software to give access. What's your Facebook name? Edward Reyes. Okay, I'll have a look in the Facebook, and like if I can, I will give you the access. But again, if I can't, then you have to wait for 3 days. Any question, guys? Those of you in the Facebook, you guys are having any questions? And anyone who wants to join the course, please send us an email at firstaidamc4536@outlook.com, or you send a message in my messenger. Okay. And I'll try my best to go through that. But again, you might not get reply immediately because of the team is absent for the moment. Unfortunately, usually they don't take absence, but this is the time. And I know that this is the admission time, but because of like real urgency, I had to give them some leave. So they took the leave. So there is no team to look after it at the moment. But again, I'll try to answer you if I can. But if you don't get answer, just send a message writing that you want to make payment and you want to join the next class on Tuesday. Then I'll give you very quickly, I'll give you the Zoom ID and password and you should be able to join the class. Okay. All right then. So we'll talk with you again on Tuesday and you should be able to get the schedule as well by tomorrow. So see you soon again. And if any of you want to join, feel free to contact with us. Thank you all. Have a good night. Bye.